Okay, a very warm welcome to everybody to the session on universal health coverage in India, critical areas of policy reforms and research for better engagement of CHWs. This session is the last session in our webinar series of community health workers, frontiers of thinking and evidence. Before we begin, I will just go through some ground rules. We would be recording this session, and in case any participant would not like to be recorded, please let us know and we will take a note of it. We request all the participants to keep sharing their thoughts and reflections in the chat box. Kindly post your questions in the Q&A section. It has the option of upvoting and commenting on other questions as well, so we can decide on the priority. And the questions will be taken up during the dedicated Q&A round. And if you're sharing reflections from this session on social media, please tag us at OPM Global and WGHI India in your post. Just to briefly run through our series, today we present the sixth and the final session of the webinar series. This series is hosted by Oxford Policy Management India Office and the Women in Global Health India chapter, which is a collaborative to talk about gender and associated issues in the domain of global health. Our series actually aims to really engage with the evidence and deliberate on the evidence on how it can be utilized to interpret it into policy and reforms. We've tried within the series to have different stakeholders speak on various aspects of CHW programs and CHWs as well. That's why we've had health workers to researchers to policy practitioners to state representatives and also civil society members. We have tried to touch upon some aspects of use of technology, the constructs relating to empowerment, power dynamics, and the social location of the CHWs themselves. Today, it's my privilege to introduce our panelists for the session. They are very well recognized across the globe for their contribution in knowledge building as well as health systems practice. Their work speaks of their commitment and the depth of their experience and a nuanced understanding of community engagement across health programs, policy, and research. First off, we have as a keynote speaker, I would like to welcome Dr. Henry Perry. He's associated with the Department of International Health, Johns Hopkins Bloomberg School of Public Health. He has published widely across the subjects of primary healthcare, health, human resource, community-based approaches for improvement health outcomes. He also provides support to various countries through on-ground assistance in programs. He has a rich experience on health management and evaluation of health programs in developing countries. He's also a founder of an NGO called Cura Americas Global, which is now working in Bolivia, Guatemala, Haiti, and Liberia. Welcome, Dr. Perry. Next, we have Dr. Rajni Ved, who is currently an advisor to the Ministry of Health and Government of India. She is a public health physician and implementation specialist in community-based health service delivery, health system strengthening, and in scaling up. She has played a key role in policy and implementation support for India's ASHA program. She has been a key person in designing the primary healthcare reform with the health and wellness centers and led several initiatives on behalf for the government of India. She's also established the implementation research platform for health system strengthening as part of India's health mission. While her expertise lies across implementation and evidence generation and various aspects of health system, she has also been a very keen and generous mentor and a strong advocate for emerging researchers like me, and has been an implementer across India. She has been recognized for her public service through the Sam Adiji Distinguished Public Service Award for her leadership in evidence-based policy and health system strengthening. Thank you, ma'am, for giving your time for the session. Next, we have Dr. Uta Lehman. She's a professor at the School of Public Health at the University of Western Cape. She's worked as a director at the School of Public Health. She's also been associated, and her keen interest lies in the areas of human resource development, monitoring and evaluation, and qualitative research. She has extensively worked with the WHO and as a member of a Rockefeller Foundation, Rockefeller-funded Joint Learning Initiative on Human Health Resource. Next, we have Dr. Devki Nambiar, who is also a program head at the George Institute for Global Health in the domain of health systems and equity. She has a rich research experience across many Indian states and many countries as well. Her keen interest lies in research and action on the social and political determinants of health and health reforms in resource-poor settings. She has also been a former Fulbright Scholar and received awards from US National Institute of Health, Wellcome Trust, and many more. She advises the WHO on health inequality monitoring and support policymaking in India on universal health coverage and urban health reforms. For this session today, we have Dr. Rakesh Parashar as the moderator. He is the lead of the health practice domain at OPM India. He's a health systems researcher and has a wide experience right from implementation of programs at the state level till to engagement with leading partners in implementation of various public health initiatives. He's also been a HPA, Health Policy Analysis Fellow, that is given by the Alliance for Health Policy and Systems Research. His recent published work is on examining policy implementation and practices of power through a more actor-centric approach. He has a PhD in public health. Thank you so much, everybody, for providing their time in this session. Without further ado, I will just hand over the mic to our moderator to set the context. Thank you.
Thank you very much, Apna, for the nice introductions, and a very good morning, afternoon, and evening to people joining from different parts of the world. I am very honored to be moderating this immensely learned panel. I think this has been one of the first webinar series covering all range of community health worker issues, with many local and global experts participating on the panels. So today's session will focus on the role of community health workers in universal health coverage and what policy support is needed to enable their role. We will also reflect on some of the research priorities in this context. So to put today's topic in the context of universal health coverage, I'll just highlight some of the changes that have been seen across the world in the healthcare delivery landscape. So some of these are quite basics and we know about it, but just to put them in the context that we have seen a rise of communicable diseases, including issues of mental health, etc., along with the tropical diseases in the LMICs, including India. And many of these issues are related to changing environmental conditions, nutrition, work and lifestyle, healthcare access itself, among other things. Similarly, we have also seen a shift in the way the diseases are occurring, and major pandemics have taken place globally in last 2 decades. And we have seen COVID-19, Ebola, H1N1, among others. The third thing that has happened around us is the way healthcare is accessed and is delivered is also changing. This is especially because of technology-based solutions arriving in rapidly and also because of different payment models that are coming in. For example, in the COVID-19 period, we have seen in the urban areas that the reliance on technology has increased tremendously. That includes teleconsultation, delivery of medicines and tests at home. Also in the rural settings, we have seen that many drives of community-based health services have been kind of in a way increasing and also slowly institutionalizing. And we have seen more frequent home visits by community health workers for isolation, testing, need of pandemic communications, etc., etc. So all of these changes mean that the primary healthcare ecosystem in context like India is demanding a significant shift. And now this shift is a necessary part of the universal health coverage. Community health workers inevitably play a very significant role in this part because of their unique positioning between the communities and the formal health systems. It is just not the community health workers, but also the community health systems, the entire community-based systems which are integral to this journey. pandemic after pandemic, the need of these systems is being felt more critically. But then, how does policy support them if they are so critical? If they are so critical actors towards the goal of universal health coverage? And what do we need to learn more about them? What kind of research need is there? And this is the focus of the session today. We have much to discuss and learn on these different strands. But before we move on to the first part of our panels, I would like to let the audience know about the flow of this particular discussion. So we will first listen to the keynote address from Dr. Henry Perry. Then we will have the panel discussion in 3 rounds that will cover the roles of community health workers in universal health coverage. The critical policy reforms and the research priorities will follow. And then in the end, we will have about 20 minutes for the audience to interact with the panelists for their questions and comments. So now, without talking any further, let me invite Dr. Henry Perry for the keynote address to kickstart the webinar. Over to you, Dr. Henry Perry.
Okay, thank you very much, Rakesh. Can everyone hear me? I hope.
Yes,
okay, I'm very honored to be here today with you and to share a few thoughts. I have 8 minutes and I've got a lot to say, so let me move right ahead and share some basic ideas with you that I think are so critical. It's obvious to everybody, but it's nice to quantify this, the need that exists around the world. And of course, we're focused primarily on India, but we want to keep a little broader perspective as well. And so in 2019, the General Assembly of the United Nations put out these basic facts that are guiding a lot of our thinking about how we need to expand health services and how community health workers are so critical for this. We're at the cusp of a new era, I think, in which, based on these needs, it's so critical to think about expanding at the grassroots level health services. Back in 1992, Frankel made this statement, which is so powerful. He said, "There's no longer any place for discussion of whether community health workers can be key actors in achieving adequate health care. The question is how to achieve their potential." And over the almost 30 years now that's passed since he made that statement, we have so much additional extensive scientific evidence of smaller scale efficacy studies of the power of community-based approaches to improve population health. And then we have these amazing country examples where strong community health worker programs have been implemented with major improvements in population health that are widely attributed to the fact that there is a strong community health worker program present. Unfortunately, community health, community-based primary health care, and community health workers have been an underfunded afterthought. And at the same time, there's growing recognition that we will never achieve universal health coverage without bringing in strong community health worker programs. And many of us believe that community health workers should be the foundation of a primary health care system, but at the very least, it should be an essential subcomponent, which it hasn't even been able to achieve so far within the health system framework in so many countries. My colleague Uta Lehman has been a strong proponent of the fact that unless we have sound program design and management, role clarity, embeddedness in the health system and in the community, and ongoing adaptation and improvement of these programs, they won't reach their full potential. And that's been the history, unfortunately, of so many programs around the world where they haven't had these characteristics. We're now thinking of 2 major types of community health worker programs. One we call Type 1, which is a well-established program which has formally employed full-time workers working 40 hours a week. And then the second type is a less than full-time community health worker who may receive some remuneration but is not formally employed. And then we have two subsections within that type, those that work more than 10 hours but not full-time, and those that work less than 10 hours a week. And I'll go into that a little bit more in just a second. My colleagues and I produced this book, which I'm very proud of. It's 478 pages long, and it's a summary of 29 national community health worker programs. We have a wonderful chapter in there on the community health workers of India, led by Kerry Scott. And within that, you can see that comparing India to two other programs, Brazil and Bangladesh, you can see some basic features here which are important. Number one, India has the largest number of community health workers in the world. If you add up the ASHAs, the Anganwadi workers, and the auxiliary nurse midwives, it comes to about 2.5 million. And they're roughly one community health worker for 1,000 people in India. And among these three cadres of community health workers, only the auxiliary nurse midwives are a type 1, formally employed and working full-time. The ASHA workers and the Anganwadi workers are part-time and not formally employed, although they do receive some incentives. In our case study, in the book I just mentioned, the authors mentioned these challenges as being the most important for the community health workers in India. And I think it's important to keep this in mind as we move forward here. My colleagues and I published a few years ago how many lives would be saved globally as well as in specific countries, including India, if we were able to expand to 90% the coverage of community-based interventions that community health workers can provide at the community level. And as you can see here, roughly a third of all deaths of mothers and children could be prevented today if we simply strengthen the coverage that community health workers can provide. And this is just for maternal and child health for specific interventions related to them. It doesn't include family planning, for instance, and we know that community-based work can not only address maternal and child health and reproductive health, but many other issues as well, as I'll mention in just a minute. This is one of my favorite slides because it shows the potential of home visitation for improving the health of populations of people. And in this case, this is a study from Bamako, Mali, in which community health workers visited every home frequently, and they were looking for children with signs of serious illness, and they made sure that these children got appropriate treatment, either directly in the home or by referral to a nearby clinic. And you can see here that the under 5 mortality rate fell very quickly to a level approximately of that in the United States. And I have inside information that says that Bill Gates read this article and he said, if this paper is in fact true, then the Gates Foundation should be investing all of its resources in this approach. As Rakesh mentioned a minute ago, obviously we're going through the demographic transition. The non-communicable diseases are becoming more important. We've got issues of surveillance, of disease outbreaks, the critical need for stronger registration of vital events, growing awareness of how hypertension is to the global burden of disease and the unmet need for screening and treatment, which is a very simple process. And so community health workers have an important role to play in this, and we're just now beginning to see the potential of that. as Rakesh also mentioned, it's not only community health workers that are so important, but also engaging communities to help them improve their health. And obviously the two are closely related, but we need to keep in mind that we need better ways of working with communities to help them improve their health. And so I'd like to propose some basic ideas for what I think would improve the community health worker program in India, and also strengthen community engagement. So the first thing is we need to develop type 1 cadres beyond the auxiliary nurse midwives, who are really well trained, paid full time on a regular salary as civil servants, well supervised and appropriately supported with the supplies, commodities, and drugs they need. And that's what I mean by a professionalized community health worker cadre. We're going to need additional help in order to carry out all of those functions that I mentioned. And one important one, and I know that India is trying to do this, but it involves reaching out to every household on a regular to make that possible. And particularly important is the need to reach out for frequent home visits after birth to reduce the mortality of neonates, which is a big problem in India. I think the Brazilian model has a lot to offer it. India, and in that case, and I know India is moving in this direction, but there's a team of primary healthcare workers in Brazil that are led by a physician and higher level nurses, but are closely connected to community health agents, each of whom has 150 households that they are responsible for, and they visit these homes every month. But the community health workers are also in daily contact and meet with the higher level people on the team, so it creates a coordinated approach to the needs of the people. We need, obviously, to greatly expand the roles and tasks for community health workers and reorganize the way in which services are provided to deliver as many as possible through outreach services and at the home level. And this greater package is shown below here, and it's going to take more manpower to do that, obviously. But very importantly, we need to give communities a voice and real authority and oversight of the local primary health care system and engage them in the process of health improvement. I've been thinking about this a lot, and I think it's important to consider ways in which communities can have real teeth in terms of voice and authority. And I've listed here 3 examples of local control over primary health care systems. One from the United States that's a massive program now, one from Peru and one in Brazil. In each of these cases, there's a local board of directors that controls policies and budgets, and I think that's an important feature to think about. Everybody always says we don't have the money for community health worker programs, and I have never bought that. And in particular, the situation in India, I think, is quite promising, because the current amount spent in India on health is so small, and it's obviously going to grow for many reasons, but as the economy grows, there'll be more money available for health. And I strongly believe that we need to invest more in community outreach programs than we're investing in hospitals and facility-based services. Obviously, we need to invest in facility-based programs, but the rate of growth of investment in community health workers should be greater than the growth in these other facility-based programs, in my view, from a public health standpoint. What I've said today is derived from 3 documents. You see 2 up here, and there's a 3rd one that's listed below. And if any of you want to read any more about this, you're certainly welcome to, and I encourage you. And thank you very much for this chance to share a few provocative thoughts.
Thank you. Thank you very much, Dr. Perry. I think this was extremely insightful keynote and brings together so many interesting areas for the community health worker program reforms. And I think among the many aspects that you touched upon, the idea of the communities demanding care and better organization of services, health services by the communities themselves and their empowerment, I think is extremely critical. And the ideas of primary healthcare teams where community health workers are also engaged is quite fascinating. I think with this kind of roles that we are discussing, we have a good segue into our first round of discussions with the panelists, where we are going to discuss about the expected and potential roles for the community health workers. So I would like to ask my first question to Dr. Rajni Vaid, who is one of the pioneers of community health worker programs in India. So Dr. Rajni, if I could ask, given the plurality of the possibilities for various roles for community health workers in the context of primary healthcare and universal health coverage, what do you think are the most critical roles that policy should look at?
Thank you very much, Dr. Rakesh, and good evening, everyone, or good day to whatever part of the world you're in. So looking at the roles, and I note specifically that you're talking about India, I'm going to, Henry clubbed the auxiliary nurse midwives, the Ashas, and the Anganwadi workers together. I would say that in India, we consider community health workers more related to the Ashas and the Anganwadi workers. And I'm going to focus my comments largely on the Asha program because that's what I'm familiar with. The three roles of the Asha really, although there is a vision document that was created in 2005 and said the Asha will do the following things largely related to maternal, newborn, and family planning. But really the three distinct roles of the Asha that have emerged over the last 15 years are related to, one, her role as a social mobilizer, which is basically enable people to access entitlements and to bring people together as a collective, either by herself or through being part of a community collective. The second major role of the Asha is that of a community level care provider, especially in areas where there are no health services where she can reasonably and confidently refer people to. And the third one is the role of as a link worker. And we discovered 5 years after the program was launched that these roles were actually allocated by program officers in states to Ashas depending upon their context. And while the mobilizer role seemed to be pan-India, the role of the community, the role of the Asha as a community level care provider or that of a link worker was very dependent upon the ecosystem within which she operated. So if the Asha was working in, let's say, rural Jharkhand or in Chhattisgarh or in Orissa, they had no choice but to strengthen her as a community level care provider. But in places like Maharashtra or the better off districts in India, the states and districts in India which had better access to health services, then the Asha's role became much more of a link worker. Because in remote areas, there was really no place to refer to, and where would she, it's like a bridge to nowhere. She could not refer them anywhere. The point is that I think these three roles still stand us in good stead because they are fairly generic roles. They are social mobilization, they are community level care provision where nothing exists. And as Henry pointed out, now moving to non-communicable diseases, screening is something that Ashas can do. In fact, they are doing it in many places. So community level care provision, if you will, whether it's screening, whether it's following up on treatment adherence for non-communicable disease management, and that of a link worker. In fact, as health systems strengthen and infrastructure improves, the role of the Asha as a link worker becomes a little more prominent because there is a place that she can refer people to. But what is the change that I foresee as a result of the primary healthcare reform work that's going on? Clearly, the Ashas have now become part of a team. I would say that that was a design on the part of the design process to say that the Asha should not be by herself in the community, even though she's linked to community collectives. She needs to be part of a primary healthcare team. And so that's how it's designed now, with roles being clearly allocated. Of course, it'll be a while before each one's roles sort themselves out, and the role of the Asha then I foresee will be linked much more to health promotion, health prevention. And as we saw in COVID, and that leads me to also the role of the Asha in outbreaks, disasters, and pandemics. In the last 15 years, there have been natural disasters, there have been outbreaks. And the ASHA has actually come up trumps every time, because she works in remote areas, and because there are hardly any areas now except Tamil Nadu and Goa and Pondicherry where we don't have ASHAs. The rest of the country we have ASHAs. And so whether it was floods in Uttarakhand, whether it was communal riots in Assam, the ASHAs have always played a great role in disasters and in disaster management. But I think that enabling a community health worker to play a role in pandemics, in addressing non-communicable diseases, also means that we have to look at the entire ecosystem around the community health worker. The community health worker alone cannot do this unless we enable her through training, through supportive supervision, and provide her with the kind of tools she needs to equip herself to manage these situations. So I think I'll stop now. And if you have any follow-up questions for this.
Yes, this one more question related to what you already spoke probably, which is about how do you see the priority roles that community health workers, or say ASHAs, can play when it comes to the pandemics and other disasters? So you've already reflected on that, but any more comments or more?
So in COVID, we saw classic examples. She was undertaking surveillance, she was following up on migrants, she was, in fact, the most important thing, enabled continuation of essential services. She was, because she was part of the health system, able to refer people, to escort people in need of care, distribute medicines for non-communicable diseases. So I think it showed us a whole new part, if you will, of the tasks and role of the ASHA. So I think there is again, we have to worry about workload, we have to worry about remuneration, we have to worry about training, support, and supervision. But having said that, I think the ASHAs, the community health workers in general, can take on a lot more complex roles, provided we support them to do so.
Thank you. Fantastic. I think the whole idea of using an ecosystem approach and building the entire system rather than focusing on specific services is critical. Thank you. So now I would, in continuation of this, we'll turn to Dr. Uta Lehmann, who again brings a lot of perspectives on community health worker programs from various African and LMIC contexts. So Uta, in your article in BMJ, which is a widely read one, you talk about universal health coverage and what are the systems requirement for effective large-scale community health worker programs in that context. And you have also discussed the typology of roles of community health workers within that. So considering the evidence from African countries and other LMICs, what roles do you think community health workers can play more effectively towards the universal health coverage journey? If you would like to reflect on that.
Thanks, Rakesh, and good morning, good afternoon, good evening, everybody. Thanks a lot for inviting me to be part of this really important conversation, which is very close to my heart. It's a particularly interesting, nice conversation because it actually zooms in and out between the global and the local. And I want to just zoom out a little bit and follow up from what Rajni said about widening the lens a bit. I think it is important that we are discussing community health workers here in the context of UHC. I think it's important to remind ourselves that UHC is considered a vehicle towards achieving the SDGs. And we have to think not only about SDG 3, which is about health, but also about 1, which is no poverty, 2, no hunger, 5, gender equality, and 6, clean water and sanitation, and arguably also 8 and 10. The reason I'm raising this is because in my view, it is important for this conversation to, as Rajni said, widen the lens beyond access and equity to healthcare, which is the focus of UHC and of course very important, and to think a bit more comprehensively about health and well-being of people and communities. And that's very much what both Rajni and Henry have talked about. And sort of in my conceptualization, the concept of comprehensive primary healthcare actually does that a little bit better than what UHC does. And so I think reframing the question to look at what roles community health workers can play as part of comprehensive primary healthcare towards achieving UHC and the SDGs is actually useful. And in that context, I want to make a few points that are quite closely linked to what Henry has said already. and which I think will help us internationally, both in our academic debates and policy debates, to come to grips with grips with ways going forward. I mean, the first thing is that community health workers, the concept is actually an incredibly blunt conceptual and policy tool. And I think increasingly it stands in the way of coherent conversation and appropriate policy decisions. I mean, as Henry has pointed out, and also he's shown the typology, community health workers constitute numerous close to community providers. In some cases, they are simply government civil servants, have 1 year of training, are employed by the state, are servicing health posts, are accountable to the formal health system. In other countries, there are entirely volunteers involved in a wide range of activities, very little training, very little link to the health system. And then there are a range of combinations, often quite messy and disorganized, driven by a wide range of interests. And then there are some countries, Ethiopia, I think, is a good example of a reasonably successful, not without major flaws, and systematic and deliberate combination of these. And the fact that we continue to conflate healthcare providers at the community level into this cadre community health workers obfuscates rather than enlightens our understanding of what makes a good program. And it makes the question what role they can play actually impossible to answer, because we're in fact comparing apples and oranges. And I think in our conversations, we have to become much clearer about role definition, expectations, and so forth. So just to say that the role that community health workers can play depends on a couple of things that are interrelated. It depends on who becomes a community health worker in terms of gender, age, education level, standing in the community. It has very importantly to do with how they're trained, how well they're trained, how well they're supervised and supported. It has to do with how their roles connect and integrate with other systems, so other systems in the health system, local government, education systems, and how they interact with these layers and how the wider system enables this interaction, very importantly. It depends on how well they fit into local contexts, histories, practices, cultures, and so on. It depends what incentives there are to become a community health worker. So that has to do with, do I want to be? Is it something I want to be? Is there a career path in it? What other incentives are there? And then obviously the question of adequate resourcing. So this question of what role can they play can only be answered in relation to all these factors, I think. And in my view, very importantly, it's quite important to be clear that there is no normative limit. There is no normative definition of the roles they can play. And international evidence overwhelmingly backs that up. So I think the sooner we start to differentiate and then talk about the question of roles in those wider contexts, the sooner we will get to an ability to formulate the programs and roles and so on within context, broader health systems contexts. I think I'll stop there and maybe come later to this later in the conversation.
Thank you, Uta. I think very interesting insights, talking about the heterogeneity that is there in the community health worker programs and the type of the community health workers themselves. And absolutely agree that the roles in different country contexts could look very different. So if you could also like to reflect, Uta, very quickly on maybe a couple of points on some of the constraints or capabilities, maybe taking example of a country context that might look like Indian context, and talk about, what kind of constraints we can imagine when it comes to, kind of formalizing community health workers into a role towards primary health care ecosystem or UHC.
I mean, I won't talk about the Indian context because I simply don't know that well enough at all. But I think, I mean, if we think internationally, the constraints have very much to do with what I mentioned. It has to do with, as a rule, and also what Henry started out his talk with, to say that very often they're an afterthought. They're not considered an integrated and important part of and the foundation of a primary healthcare system or health system more broadly. They're considered a cheap and add-on solution when everything else fails. And it has been argued for many, many years. I remember there's an article that is first authored by Lucy Jilson from 1989, which says community health workers are not the panacea. They cannot shore up broken health systems, but they can be very important in supporting and improving the outcomes of functioning health systems. And I think that is a crucial lesson, which is as true today as it was back then. Thanks.
Absolutely. Thank you very much, Uta. It's very interesting. So with the idea of the integration, we have a couple of linked conversations in the second round. Before that, I'll move to Dr. Devaki Nambiar, who has also widely published on universal health coverage and community health worker programs. So Devaki, over the years, the role of community health workers, as earlier panelists also spoke, has been expanding beyond, say, maternal child health care and moving into mental health and non-communicable diseases. So it would be also great to hear your reflections on the implications of this kind of expansion towards the goal of universal health coverage.
Thanks for this question, Dr. Rakesh, and thanks to the others who've spoken before me and sort of laid the Indian and global landscape. I must confess at the outset that my comments draw from about a decade of work exploring aspects of the ASHA program specifically in India. So I'll be able to speak in a limited fashion to that program. And then of course, UHC more broadly and the meaning that has for that. And some of these observations range from the Mitanin program in Chhattisgarh through to a meeting that we had just last month on the rights of community health workers, which featured a number of ASHAs articulating their rights and demands as well. And I think that's sort of the direction in which, as I see it, the conversation needs to shift more broadly, but more on that later. To add on to what others have said, to the extent that we place communities at the heart of UHC, we're talking about people-centeredness, and in my view, the heart of that heart really is the community health worker, which is, I think, what Professor Perry was also referring to. And the heartbeat, if you will, as Professor Uta was saying, is CPHC, right? That's where the articulation of the roles really sort of happens. And so there is no doubt that community health workers and community health plays a seminal role in achieving universal health coverage and comprehensive primary health care. And we can see that, as you yourself have said, in terms of the expansion of services following from perhaps the UHC cube logic. And this has been demonstrated for a while now, close to a decade or maybe even over a decade, in terms of within the frame of task shifting, the fact that a lot of the roles pertaining to chronic care, pertaining to linkage to services for mental health, conditions, these roles can be fulfilled by ASHAs, by a number of other types of cadres of frontline health workers as well. This is borne out in sort of systematic reviews that my institution has done, for instance, as well as a lot of research, including the WHO guidelines that came out in 2019. So certainly this is the case, and there are implications of this. And if you'll permit me to be a little shameless, we had the luxury of of Dr. Ved serving as a distinguished fellow at the George Institute, where she talked about this idea of paradigm shifts as we think about this expansion of roles and the remit of UHC and what that implies for ASHAs. I'm just going to paste, if I can, into the chat her wonderful thought piece on this, while also giving you some highlights from it based on some of the research we have also done. And I think one of the aspects that she gets into that I'd like to talk about here is this idea of leave no work behind, okay, which is what's happening with workers like ASHAs. So you're moving from episodic care or care based on sort of antenatal care through to delivery and postpartum care to long-term follow-up care and really sort of across the life course type of care. So this requires serious sort of consideration, policy and programmatic design that enables this. And perhaps it actually requires additional health workers. In fact, that's the case that Dr. Rajni makes. And I think a lot of us feel that this is adding another worker is a critical component of offering that kind of support on the front line. Whether that is another ASHA worker who is a female or an Ashok or a male multi-purpose health worker is a matter that will be dependent on the context in different states in India and certainly in other countries. I think another dimension of this path towards UHC has to do with task complexity, as Dr. Ved also points out. This requires various levels and registers of engagement and management that frontline workers have to carry out, not least linked also to using digital platforms and to using multiple systems related to different programs and sort of having to navigate all of those. So we're seeing that also as part of what is entailed for frontline health workers. And certainly in terms of maintaining the care continuum, moving, expanding the scope even within a disease domain through to the prevention promotion aspect, and perhaps even extending into sort of financial risk protection areas, those types of expansions are also important to consider. What we have done actually in the past year is kind of at this pivot point, as in India, ASHAs are expanding their role. We carried out a time motion study just to sort of understand how frontline workers are spending their time. And, we interacted with about, in Delhi and UP, we interacted with 26 ASHAs over 78 person days, some 3,000, close to 4,000 observations, and similarly about 25 ANMs, again, about 75 person days. And there were some striking findings in terms of what workers are needing to spend their time on. ASHAs, as you can imagine, with their very strong domiciliary role, spend a great 29% of their time in our study was spent on travel, right? Just getting from place to place. This is travel that is not compensated, it's not paid for, it's out of pocket. And quite often we've heard in research studies that ASHAs are spending money on other people's travel or facilitating travel for the community members they are supporting. So there are a whole lot of these additional roles and tasks that are emerging for ASHAs and for ANMs as well that we haven't quite noticed and that our research needs to take sight of and that the UHC model needs to accommodate. In ANMs, among ANMs, the tasks related to administration occupied, again, close to a third of their time. And if you can imagine, and so that is work like filling registers. I think a lot of us can have seen the sort of painstaking level of register filling that ANMs are having to do, maintaining records, working on linkages with ASHAs, supervising them, working with medical officers. So particularly as task complexity increases, we can expect that the load in terms of these kinds of roles will also increase. And I think, these seem very mundane, but they're absolutely critical in terms of actually operationalizing what UHC has to mean in terms of achieving broadening the service coverage base. So I think it'll be very important for us to pay much closer attention to what the continuum, the task complexity, the use of digital technology, what it helps and hinders as we advance on the path to UHC with frontline workers. I'll stop here. If you have another question.
Absolutely fantastic and very granular insights, Devki. So I just have a follow-up question, and we are also kind of shooting beyond time for this this round. Just one question: how do you also see this kind of expansion, meaning differently for marginalized communities compared to more well-to-do communities?
Yeah. So here again, Dr. Rajni's piece will give us remarkable insights on that. There is the piece about expanding population groups, right? Moving from MCH care to NCD care. And I can put in at some point a study we've done on looking at service gaps in terms of coverage of APL, BPL, male and female populations for hypertension and diabetes screening, again in Delhi and UP, where the time motion study was carried out. And we were seeing that males are getting left out. And, to some extent, that's not a surprise in many states of India, that it is not an automatic thing that you can expand this continuum, you can expand the scope of services. And ASHAs will be able to pivot into, talking to men, doing a risk assessment with them, asking them if they drink alcohol, talking to them, doing waist circumference measurement and things like that. So, it'll take some time for that kind of inclusion really to happen in terms of their service delivery. We also know, in our study, we didn't find differences by poverty status, but we do know of caste-related exclusions. I think someone in the chat has already pointed out the exclusion of migrant workers. And, to some extent, these are exclusions that are really actually by design. Because we've been so MCH focused, it'll take us some time to kind of widen the base and widen the population coverage in terms of the leave no one behind agenda. And also the fact that we use a population norm-based approach, which is focused on the rural sort of model of NRHM, that doesn't do a great job of looking at very small populations of tribal or Adivasi groups. It doesn't do a good job with migrants. It doesn't do a great job with populations like the urban poor or the homeless and so on. So we have to really be innovating, and a number of states have done some thoughtful work on this, but we need to pay much closer attention to the inclusion dimension of what ASHAs are doing, so that various population subgroups are included, and also acknowledge that in many cases ASHAs are playing an activist role in terms of advocating for their communities, but that they might have some blind spots in terms of communities that are truly really underserved and require a lot more support for them to be able to reach and play that role of a health equity advocate.
Absolutely. Completely agree, and this is not just about having all the expectations from ASHAs, but also about the kind of support that can be generalized, and that is where our second round of conversation starts, and we will talk about the kind of policy reforms and the support that is required for community health workers. So once again, I'll start with Dr. Rajni. So Dr. Rajni, from a very practitioner's lens, how do you think we can effectively allocate resources to community health worker programs when it comes to the journey towards UHC?
So Rakesh, I hope when you say effectively, you also mean adequately, because I think you could say effective but not say adequate, and then you can just say we'll allocate money to this and not to that. So I think first and foremost,
important nuance.
Policymakers have to recognize that the ASHA or any community health worker program is not an inexpensive substitute for human resources. It is not. She is a very valuable, and as you heard all this while, very valuable member of the primary healthcare team. And in order to make primary healthcare, particularly comprehensive primary healthcare, a reality, we will need to invest in her. India, although I think we have done a fairly good job of actually articulating in policy and following it up with funding, of allocating funds for the support system of the community health worker program. So in addition, and this is a fact I don't think too many people know, is that in addition to the incentives that the ASHA may receive for newborn care, for escorting women to hospitals for institutional delivery, there is a separate program budget. And between the two, the program budget for the ASHA, which includes the salary of an ASHA facilitator, a block level and a district, a successive level of support at the state and district and sub-district levels, together they account for almost 10 to 12% of the National Health Mission's budget. And the National Health Mission, as you know, is a large proportion of the Ministry of Health's budget. So I think in terms of articulating in policy, there is what I would call adequate and effective. My issue, however, is that unless you fully remunerate a community health worker, the point that Henry made in his presentation, is a fully paid community health worker. You cannot have a volunteer remunerated for task-based incentives and then pile work upon her and say that we'll give you the incentive for this. You see that, I think that's where, in a sense, I can't find another word for exploitative, but a system that recognizes that here's a woman who's working in the hope that she will get a government job someday, because let's face it, that has been the motivation for many, if not all of the ASHAs, is that financial remuneration and the hope of getting a government job has been what has kept them there. In addition, of course, to having gained the social capital, the credibility, the link with the health system, all of these have been important factors, but remuneration has been and a full-time job. But not to do that and continuously increase the number of incentives for the ASHA doesn't contribute to a long-term, strong, robust, sustainable community health worker program. And if we want to achieve primary health care, we are dependent, not on the ASHA alone, but the team, and the ASHA is a valuable member of the team. Having said that, I think we also need to figure out what are the alternative ways of financing a community health worker program. In many countries, certainly there is international donor presence, and in many of them which do have community health worker programs, they are domestically funded. Now, whether this domestic financing also includes support costs, incentive costs. In India, we also have costs for career progression. We actually support the ASHAs to gain educational equivalence for class 10, for class 12, and go on to become either nurses or ANMs. And the last I knew, we have almost 1,200 to 1,500 ASHAs who've actually gone to nursing school and become either general nurse, midwives, or BSc nurses. So that has been included. And I think as a country, we've done a fairly decent job of allocating resources to community health workers. But I also, this is an issue with, and I've lost a bit about domestic financing, is that when domestic financing alone is not sufficient and donor financing is added into the pot, then the risk of having the community health workers do vertical programs or disease-specific programs, you do run the risk of doing that. And therefore, as a policy initiative, I think countries should be looking at domestic resources, particularly for community health workers. I've heard talk, and there used to be a report, I think written 5 years ago, on making an investment case for community health workers, in which they had suggested private sector financing. I think including private sector financing within the mix of making resource allocations for community health workers doesn't sit very well, particularly in poorly governed areas where referral to the private sector could actually become a potential hazard. And that in its own way is exploitative, leads to high out-of-pocket expenditures. I think in terms of resource allocation in federal structures like India, a balance between what the federal government puts in and what the state government puts in is also important. In India, we have this good experience that in many states where they recognize that the ASHA is a critical component of their health system, several states have added on equivalent or a high percentage of what she gets from the central government budget to the allocation. So in some, at the national and the state levels, adequate and effective allocations for the ASHA would include support for her incentives, and I would say a full-time salary, support structures, and being able to provide her the drug kit and including career progression as well.
Thank you, Dr. Rajni. I think very interesting insights again, and you have touched upon not only on the issue of the remuneration and the kind of salaries or the compensation that is required for the full-time, in fact, more than full-time work that they do, but also about the alternative mechanisms that need to look towards their career progression, other support mechanisms. So very interesting points again, and this time I will again like to move to Dr. Uta for her views on the policy reforms which are required towards community health workers integration. So Uta, in your commentary from community health workers to community health systems, you identified embeddedness, connectivity, and integration as some of the key ingredients for larger scale community health programs. So what do we know about how policymakers can really ensure that these programs are integrated into the mainstream health system? Something you also mentioned in one of your previous comments.
Thanks, Rakesh. And I think I will make just one point here. And it is about sort of widening the lens a little bit again to move from sort of focusing on community health programs to actually recognizing and better understanding community health systems as a whole, and to think about their interface with and the integration into the community health systems and health systems. And I think that is what embeddedness, connectivity, alignment, and so on is all about. I think that's an important distinction because, and it's important to say that community health systems are embedded in multiple systems. So in the wider community, formal health systems, other education systems, and so on. So that it's a very multidimensional set of systems, and Henry Perry and others have illustrated this very nicely in their publications. My colleague Helen Schneider and I, and also other colleagues, have written a little bit about how we conceptualize community health systems. And one of the definitions that we've come up with is community health systems as sets of local actors, relationships, processes engaged in producing, advocating for, and supporting health in communities and households, outside of, but existing within relationship with the formal health structures. So it's much broader than community health programs per se. And I think that is important because it recognizes that if we think holistic design of programs and policies, they then have to grapple with the intangibles, the complexities of, and the multidimensionality of local, social, cultural contexts, local politics, histories, economies, and so on. And that then requires policymakers and managers, and in fact, very importantly, also NGOs and international NGOs and donors, to really tune into and to be prepared to take their cue from and be responsive to the needs, the priorities, the specificities of communities. And of course, that's not an easy thing to do at all. I mean, we talk a lot about community health programs need to be context specific and need to be local, but the practice of that is very, very complex. And one of the challenges for even very well-meaning policymakers is that this need of being tuned into local realities and local politics and cultures and so on confronts and runs counter to the rigidities and the rule-boundedness of large public systems, which as a rule in most parts of the world, I think, have very top-down structures, are very hierarchical, have their own priorities, have their own political agendas. So policymakers and local managers and so on also straddle a complex set of competing agendas, of priorities, and not always very harmonious relationships. And I think we've seen some of that in the last year in the context of mobilization around COVID, around trying to prioritize resources and so on. Getting that right is a rare occurrence, I think. And yet I think the success of vibrant community health systems relies on it. So it is worth the investment, because I believe that ultimately the success of universal health coverage, of comprehensive primary health care, and of community health worker programs hinges on that vibrant, confident, proactive, mobilized community and community health systems, because only then do you have a sort of a productive, mutually respectful engagement that can create solutions that work in local context as part of a wider system. Thanks.
Thank you, Uta. Again, very insightful comments. And I think I really like the idea that first you discussed about the heterogeneity in the community health workers, and then you're also talking about the local contextual requirements. With that, the policy makers have to really engage in a much more nuanced manner. So I think with that, I'd like to link this with the political commitment and the political will that is required. And that's my next question. And that goes to Devaki. Devaki, one of the key challenges, again, in the community health worker programs is the political will and sustainability of these programs. For example, in India context, we're talking about a lot of NHM-based mechanisms, and the integration into the mainstream systems is challenging, right? So would you like to reflect on any thoughts as to how the researchers or practitioners can build or support this kind of political will that can help these programs?
Thanks, Rakesh. I think, you know, I mean, I know that we in the Indian context, we quite often worry about the tenuousness of the National Rural Health Mission and that it's in mission mode and, you know, could the ASHA program be scrapped? But I mean, let's think about that. There is such incredible political capital and momentum within that workforce. They are a force to be reckoned with. So I am quite optimistic that it is unlikely that a program like this will be scrapped. It may be transformed, it may be scuppered a little bit, but it is really built to last at this stage. But to me, and I'll make a short point just in the interest of time, I think there's the issue of exploitation that Dr. Rajni has raised is sort of central to me, particularly in large publicly funded community health worker programs. In other parts of the world where there are smaller ones, you know, it's really that integration. And I think there's a lot of advocacy right now for community health systems with community health workers. And I think there will be sort of political peer pressure across member states to bring that in. You can see even in the US with COVID, concern raised that, you know, why don't we have community health workers that are publicly funded, you know? So I think there is momentum around that. But when it comes to cases like of very large programs like what we have in India, I'll just illustrate a quote we had from an earlier study that we did where, you know, everybody knows the ASHA, 99% of the community knows the ASHA. And we asked an older woman, and she just brought up in the course of conversation, we said, you know, what is the name of your ASHA? And she said, ASHA ka naam koi nahi janta. So I'll say this in Hindi and then I'll translate. ASHA ka naam koi nahi janta. Jab sarkar ne itna acha naam diya hai, ASHA, to uska dusra naam janne ki kya zarurat hai, right? So the government has given such a great name, ASHA. ASHA actually means hope, right? So then what need is there for another name? And I mean, on the one hand, this is, you know, it's very encouraging and uplifting to hear this, that there is such embeddedness, there is such branding associated with the ASHA sort of program, such embeddedness. That's very encouraging. And that makes us think about sustainability and political mileage that the program has. But on the other hand, it's vexed because the more embedded the ASHA is in her community and indeed in the health system, the less she defines her role, the less she can assert her own rights, the less she is recognizable, right, as an individual with a name or whatever else, right? So there is this sort of contradiction in terms that we see. And I think that some of the suggestions that Dr. Rajni had in terms of, you know, career pathways, thinking about actual proper compensation, and really ultimately the idea of the ASHA as a worker, really recognizing that, thinking about it from a labor perspective, as even Kasturi was saying, I think is critical. In terms of the sustainability issue, to me is frankly secondary in the Indian context. It's the ethical and moral imperative right now to do right by these workers. And so I think really working on sort of even forms of tripartite governance, where it's, you know, the community, the workers, the health system, thinking about how to govern and give voice to workers as they speak, as they serve as a bridge in the system, will be particularly important for a country like India going forward.
Thank you. Thank you very much again for a great thought. And I think the idea of first handling the exploitation that we are talking about in a way is definitely more critical than anything else. So before we go to the next round, which is a shorter round, I would once again like to invite Dr. Henry Perry, if he would also have any reflections on some of these policy reforms areas that have been laid out by our panelists. Yeah. Dr. Perry.
Yeah, thank you, Rakesh. This has been a great discussion, and our panelists are really terrific. I'm so grateful to be a part of this discussion and to hear what they have to say. From the policy standpoint, I think two issues are important, and one or two people have mentioned this in the chat box, but the issue of political will is so important in this, and there has been so little broader political will that brings to the forefront the need for stronger community health programs and community health workers. The 2008 World Health Organization report on primary health care brought up a concept that has been central to my thinking, which is a counterbalance to the community health worker and community health approach, and even the primary healthcare approach more broadly, and that is the concept of hospital centrism. Everybody all across the world is so enamored by hospitals and the myth that hospitals are the key to population health, and it's absolutely not true. But you know, the United States, I guess, has been a leader in promoting this, and we've got to move beyond that. I mean, politicians want to have in their own area of responsibility a fancy hospital and you know, high-class quality care, which is based on the westernized model. And of course, the work from John Kidd, the pioneering work from John Kidd in the early 70s and the Declaration of Alma-Ata, they all are trying to point us in a different direction, which we're still struggling to do. And so until we have a better voice from the grassroots about why these programs are important, we're going to be subject to the political interest of local elites and national elites as to why we need to invest more in hospitals and higher level facilities. And unfortunately, there's limited, if any, evidence about how investments in these higher levels actually improve population health. So improving population health is a government function. It's a public health function. And so I strongly believe that we need to have better, transparent measurements of what the government is spending on hospitals, on higher level facilities, as opposed to outreach. And I've been looking for this, and I'm absolutely confident that what we're spending on outreach is just a tiny, minuscule portion of the overall health dollar. And until we have good measures of this, and until we can bring political pressure to insist that the rate of growth of investment in community health is greater than the rate of growth of investment in higher level facilities, we're going to continue to face this problem. And so it's not an easy one to solve, but I think it's a critical one.
All right. Thank you, Dr. Henry. I think this is some of the most fundamental questions to really ask as to, you know, the goal is the population health, and if the goal is population health, where should the resources go? And community health worker programs is one part of that can really make the healthcare embedded in the communities themselves rather than being facility based. So thank you for very much for this comment, Dr. Henry. We will now move towards the final round of discussions in this fabulous you know, series of comments from different panelists, and we'll talk about the research priorities that are at hand if we have to really ensure that the community health worker programs really reach the kind of goal that we're looking at. So I'll start with Devaki this time, and I'll request all panelists to suggest the two key priorities that they see are important in this kind of aspect. So Devaki, over to you for your reflections on the research priorities.
Thank you, Rakesh, for a very difficult question. But I think I will sort of reiterate the sort of logic of what I was saying earlier in terms of recognizing ASHAs as workers. And Kerry Scott and others have done a wonderful review some years back on the looking at the Indian health worker program, and they called for, and I quote them, emancipatory research that engages ASHAs as agents to identify and work towards addressing challenges, and predictive research that helps guide next steps, end quote. I really couldn't have put it better, but I think the idea is to stop speaking for ASHAs. Like, they should be on panels like this. They should be able to articulate agendas, and we should sort of get out of the way, really, and support some of the support and better document what's happening. And I think this points to my second area of research, which is around the idea of learning health systems. And there have been some innovations around that in India, and the Alliance for Health Policy and Systems Research is also doing some really critical thinking around this. And I think the idea here is to really train the spotlight on embedding the learning, not as discrete projects, but within system functioning, right? And creating opportunities for inbuilt improvement of systems functioning through implementation research and sort of embedded research, using approaches like co-production with implementers, with decision makers, and really tightening that cycle of research production, paying more attention to what's happening on the ground. And quite often, I think there are solutions there, but they're just not being documented, they're not being researched. So just paying closer attention, really, I think could be another focus area.
Great. Thank you very much. I think it's absolutely critical to be with them and in the context that they are living in, identifying those contexts, and then really come to these forums. So no doubt about that. I'll move to Dr. Rajni Vaid now for her reflections on the research priorities.
Thank you, Rakesh. So, you know, I'm looking at 3 broad streams. I know you said 2, but I'm going to say 3. One is from a purely pragmatic and some might say instrumental point of view, is looking at functionality of community health worker programs, their performance, not so much as to judge them, but to see how we can do better, those of us who manage programs. So that is one field of research that has to be continuous and concurrent. Call it assessment, call it what you will. I would like to call it research because it looks at how you can do things better, what are the right questions to ask, and how it can feed back into policy. The second area of research, I think, needs to focus much more on issues like what are the social and technical complexities? You know, things emerge. It's not a static environment that the community health workers are working in. I mean, look, even in India in 15 years, things have changed so much. They were not part of teams. They were isolated workers. Now they're part of teams. But what are their social, technical, and political realities within which they operate? The context within which they operate. And that allows us really to devise different policies for different parts, different contexts, if you will. And I think an important area of research is power hierarchies that operate within teams, between communities and ashas, especially given contexts like ours, where you have a caste issue, you have gender issues. Looking at power hierarchy, I don't think we have done that much research in that area and contributing to policy in that area. So I think that would be my second stream. And the third one, and as of course Devaki said earlier, I think it's very important now that we engage with ashas and ask ashas what they really want. I mean, we assume that we know what they want because they're part of, you know, protests, they're part of marches, and, you know, we have some studies, but I think really engaging with ashas and keeping them central to our research. I would say one more area of research in India or in other, where there are unions of ashas or federations of ashas, you know, what motivates these federations beyond being political affiliates of existing trade unions? So what are they motivated by? What are their needs? How are they being addressed? As far as I know, they're not being, yes, they do make a lot of noise, but they're not being taken seriously. So I think that's another policy or research angle that we have to look at. So that I think these would be the areas. And in addition, of course, to identifying areas, we need the institutions, the individuals, and the capabilities to be able to do this. Thank you.
Absolutely. And I think that in itself is an area to explore as to how we can build that, you know, local capacity to do that kind of research, but all very important areas, Dr. Rajni. Thank you very much. Over to you, Uta, now for your reflections on the research priorities that you see.
Thanks. It's very nice to talk last because that way you can just agree with what the previous speakers have said and then add a couple of others. So I completely agree with the crucial importance of those identified research areas. I think in addition, this whole issue of governance at the interface between community and health systems is a really important one. So developing models that, understanding better and developing models that allow for a more engaged and mutually respectful interface in both policy and practice. So I think that is an area. And then one quite specific area, I think, we are beginning to understand the importance of community health worker programs in urban contexts, and colleagues, including Rajni, are involved in a really interesting webinar series around that. I think that is something that isn't there is a lot more work that needs to be done. I mean, overwhelming amount of research has been done in rural areas. We're beginning to look at urban areas, but I think that becomes increasingly important. So how these function in urban contexts, I think, is another important area. Thanks.
Thank you very much, Uta. And I think again, very interesting points. And because of the unique location of community health workers, these interfaces are really to be nuanced much more. And I'm sorry, I left out Dr. Henry, who was supposed to start this round of questions. So I'll request Henry, if you could also reflect on the priorities that you see are important for the community health worker programs, and you already have a comprehensive paper kind of coming up, which talks about a lot of these areas. So over to you for your reflections.
Thanks, Rakesh. The first thing is that we need more money to support research. I mean, if you look at the amount of money that goes into research on other aspects of global health compared to what we have for community health and community health workers, it's minuscule. And the Gates Foundation is certainly in a position to make money available for research. And there's sort of two ways of thinking about research. First of all, and that is research that would be available to independent groups, academic groups, technical groups, to formulate their own questions and explore them. I think this sort of independent approach is terribly important to foster real progress in this area. We need to empower researchers to look at issues and questions. So I would urge that. Of course, we need more internal monitoring of programs to help them improve as well, and I strongly support that. We need an attitude change, in my view. If you look at any community health worker program anywhere in the world, it's going to have all kinds of blemishes and warts and defects, and it's very easy to say that these things aren't worth it. But we need an attitude change so that the goal of this is to help each program where it is move to another step of improved performance. And the mental attitude, the paradigm shift is we need to be thinking about how we can help these programs achieve their full potential, because we know that they can do so much more than they're currently doing. And so research needs to help us. I think one other, I want to support heartily what everybody else has said, particularly giving community health workers a voice and even letting them lead their own research. That's been a neglected area, and it's coming, but we need much more of that. Then I think finally, we need to document better and understand why there's such an enormous disparity between what we know is evidence that can be that's effective in terms of community-based interventions and what's actually being practiced. And to me, one of the most stark areas of this is home-based neonatal care. The number of lives that can be saved through home-based neonatal care based on scientific evidence is extraordinary. And what we've done, I know India is trying, but I mean, there's so much more to go in terms of applying evidence that we know that will save lives. And we need research to understand what the gap is and what the problems are and diminishing the gap.
All right. I think great suggestions again, and I really like this idea that you have floated that, the services that are delivered at home by the community health workers have a huge potential to really improve the overall population health outcomes. And some of these reflections from the panelists about the power and gender kind of hierarchies that play out, the requirement of the monitoring, close monitoring of the community health worker programs, and the idea that the voices of the ASHAs or the community health workers themselves should be reflecting in our program priorities. I think some of very interesting comments. I would now like to move on to the next round of the conversation, which is the audience round. And I think this has been an absolutely power-packed kind of session in terms of the insights that have come up. And I'm really glad that we were able to cover a wide range of issues today. And I also hope that the audience was also enjoying the conversation. And I see that there have been a lot of comments as well in the chat box. So we will now go to the audience and we would open up for the question and answers. We will encourage the audience to write their questions and answers in the chat box, and we'll be deflecting these questions to the respective panelists. Please do let your questions come in.
So I can perhaps speak to the piece by Agrima about the varied and relevant topics with regard to rights, recognition, and resources for community health workers. So as Dr. Rajni was saying, you know, there are a number of ASHA unions and there have been a lot of agitations, particularly in the context of COVID, but frankly, even before, for these precise things, for, you know, compensation, for social security. And in various states, there have been efforts made towards improving the sort of job security perquisites and so on for ASHA workers. I think it'll take more time. And the situation of different cadres is different. So with respect to ANMs, it's different from ASHAs as compared to Anganwadi workers and so on. With respect to ASHA specifically, there is some work, there is the Community Health Worker Thematic Working Group of Health Systems Global, and the number of institutions that are part of that thematic working group are trying to have some conversations around using rights-based approaches to identify research priorities with respect to community health workers. So that it's in a very early stage right now, but do be in touch. We're kind of creating a network to sort of discuss this. I was struck by what Dr. Rajni said. You know, there has been a lot of agitation and organizing, and you know, we actually the Women Leaders in Global Health Group itself and some other institutions in India have been trying to give platforms for that conversation to start and for the dialogues to sort of happen. So I think you may be able to see the archives of at least the Women Leaders in Global Health Group and see some of those types of examples. Azim Premji has done a documentation of frontline health worker experiences during COVID. So I think there is that kind of documentation that's already sort of starting. We can make it bigger, and as Dr. Perry said, we need to resource these things. But I have a feeling that that time is very much here. It is sort of starting. I hope others agree. Yeah.
Very interesting thoughts, Dekki, thanks. And we have a lot of questions coming in by now. I'll start with the question that Helen Schneider has asked, and I will deflect this question to Dr. Henry. Dr. Henry, the question is, if the role of community health worker depends fundamentally on the social and primary healthcare ecosystems, how do we resist defining the community health worker term itself and take integrated primary healthcare or community health systems as our starting points?
So, thank you, Rakesh. Is that typed in the chat box? I'm looking for it.
It's in the Q&A.
It's in the Q&A
okay,
session.
sorry, in the Q&A. Yeah, thank you. So Helen Schneider, if the role of the community health worker depends fundamentally on the social and primary healthcare ecosystem, how do we resist reifying the community health worker and take integrated PHC teams, community health systems as our starting point? So thank you, Helen. Great to know that you're here. I would like to revert to the Brazilian primary healthcare model, which to me is such a powerful example of how community health workers can be closely integrated into and embedded within the primary healthcare system. My sense is that the ASHA workers have been relatively independent of the sub-centers, and I know there's an effort to integrate them more, but I think that we need to move towards not just focusing only on community health workers, but on the primary healthcare system, which has as its fundamental basis an outreach program. And that's why we strongly feel that community health workers and community-based primary healthcare should, if not a subsystem, be the actual foundation of primary healthcare. But they've, as Uda likes to emphasize, we've got to have these closely integrated. So in the Brazilian case, as I understand it, in most places, the community health workers, they start their day in the health center, and they have frequent interaction with the other people on the team that they're a part of, not only the other community health workers, but also the nurse or the physician who is the head of that team. And then they go out and visit their homes, and over the course of a month, every home within the catchment area of that health team is visited, but it's all integrated. And I think that's a terribly important concept to move towards, so that we're not simply talking about community health workers. I know that some people in the global health space are against talking specifically about community health workers because they see it as another vertical program. And I understand that. But if we don't talk about them, there'll be another, continue to be an underfunded afterthought. So I don't know exactly how to resolve the dilemma, but I think it's an important one.
Thank you, Dr. Henry. Yes, please. Yes, please go on.
Maybe to shift, Henry was talking about the concept of community health worker programs as important outreach programs. I think if conceptually one moves to an understanding that community health and community health programs are in fact the foundation of our primary healthcare program. So not an extension, but actually our foundation. I think then by definition, you have to think about the system as a whole, including that foundation very importantly, most importantly, and that will then allow a much more integrated approach to all areas of planning and management. So it's a small shift, but I think an important one.
Sure. Thank you. Thank you, Dr. Huta. So I'll go to Dr. Rajni now with another question, and I'm sorry we are kind of a little tight on the time on the Q&A round, as it happens often. Sorry about that. So Dr. Rajni, how do we think about the current community health organization in India, and what needs to the community health worker organization in India needs to be remodeled such a way that it fits with inherent heterogeneity of the communities by caste, religion, income level, etc. How that kind of organization can be kind of remodeled?
So one interesting feature about the community health worker program is, because in the ASHA selection, it was mentioned very explicitly that local selection and selection of the ASHA from the minority populations, whether it's SC, ST or other minorities. So actually our evaluation a few years ago, of course, and although there's such low attrition in the ASHA program that things may not have changed that much, is that across the country, ASHAs are representative of the majority of the population to which they belong. So if in a 1,000 population, there's over 50% of SC, then the ASHA comes from that, even over 30%. So we have very good representation actually. Gender, of course, all ASHAs are women. So I think in terms of, if I were asked, I wouldn't change anything about the selection process of the ASHA. Though I do worry at the very low rates of attrition, because that means we've not evolved a system of either supporting more senior ASHAs and older ASHAs who are not actually any more agile or nimble to transition out, but continue to be in the community to play a role for younger workers. We do have some policy articulations about golden handshakes and retirement. We can't say retirement because she's a volunteer, she's not a full-time worker, but we talk about golden handshake. We talk about leaving the program if you've been there for 10 years, but there are very few takers. So I think that in terms of reorganization, I think one would have to look at how do you look at this transition phase in the life of a community health worker program? So that I think that would be one major reorganize. The second, of course, has already happened. The first, integrating the ASHA into the primary healthcare team. That I think has been an important reorganizational step, and articulating it and making sure she has a role for home and community-based care. So I think that's been one that's been taken care of now. How well it's being implemented is a matter of time, context, etc.
Thank you. And that's also a question for research, I think. I think we have about only 13 minutes left now, so I'll let go of the existing questions. So we'll try to come back to the people who have asked the questions. We'll circulate kind of a follow-up note maybe on these questions. So thank you very much, everyone, for these. In the end, we have a very quick kind of a wrap up of the session, and I would like to just kind of touch upon some of the points which have been raised throughout the discussions. And I think there has been so much packed into a small session that it's quite difficult to remember all the key points. So please excuse me if I cannot touch upon everything, but I think in terms of the roles that we discussed towards the universal health coverage that community health workers can play, we discussed about the the need towards professionalization of the cadres that Dr. Henry spoke about, and their integration into the primary healthcare teams. And then we heard from Dr. Rajni and then from Devaki and Uta that the heterogeneity of the context is important to be taken care of, and the roles that we really want to look at will depend upon the kind of context and kind of the goals, as well as the the skills and the expertise that we really want to bring in the community health worker programs. In terms of the policy reforms, a few important points were that, of course, the resourcing is the critical part, and it's not only the effective resource allocation, but also to have the adequate resources that Dr. Rajni pointed out. And for make those adequate resources available, is absolutely critical to look at the different kind of mechanisms that can bring in more resources into the community health worker programs. And we discussed that the resources do not really need to go only in the kind of the services that the community health workers deliver, as well as their salaries, but also towards their support systems and the career path progression. We then discussed the research priorities, and a lot of research priorities in terms of the policy reforms, in terms of whether the community health services should be organized by the communities themselves, or whether the facility level care is more important, is an important question to look at, that Dr. Henry pointed out. Similarly, we talked about the research priorities in terms of the understanding the positioning of the community health workers and their own thoughts, their own understanding of the kind of program contribution that they do, and to bring that to the policy reforms. Then the another area was about understanding the gender and power hierarchies that play out in the community health workers. That includes other structural power hierarchies as well, including the norms of caste, as well as religion, the payment quintiles, etc. So these are some of the important areas that we discussed, and we will also try to kind of have a kind of a summary note from this event that we can prepare, and we can have all these priorities written together. Now, without taking much time, I will hand over to Deepika and Dr. Preeti for their final comments on this webinar. They have been completely instrumental from the Women in Global Health in India chapter to support this series of webinars with Oxford Policy Management. Over to you, Dr. Preeti.
Thank you very much. I think this has been quite a very exciting webinar, and this was the summary, the last webinar in the series. And Rakesh has just given a very nice summary of this particular webinar. I'm just going to take a very few minutes to kind of look back at the entire series and look at not just what the different speakers in the various webinars brought out, but also look at the kind of research that they had done and the voice of the community that they sought to portray through this research. As well as in every webinar, we've been having quite an active audience with so many questions. So kind of relooking at everything, I'm just summarizing what did we listen to, what did we learn, and what is kind of some questions probably for reflection as we go forward. So broadly speaking, in every webinar, what we found was there was some amount of the conversation, the evidence related to the individual community health worker herself. The other part was related to the role that the community played in either enhancing her performance or perhaps creating some kind of a barrier. And the third was, how does the health system play a role, again, in enabling her performance, or perhaps certain areas that still need to be overcome in order to allow the community health worker to give her best. So looking at the very first part, which is about the individual community health worker, the evidence clearly brought out this is a group of people which come into the system with a high intrinsic motivation. They may, at the beginning, may not have the requisite knowledge or skills, but it's very soon picked up because of their own high interest. And they come into it, they come into the job, and probably the only areas which I think in this webinar was alluded to in several places was the dissatisfaction with their benefits. The other point was the amount of empowerment or power or influence that they display in their own community and how they leverage the scarce resources. And in several stories, we heard of the way they have gone out of the way in order to ensure care. And the reason very often quoted was, I live in this community, and if I don't help, then how will it be? So that these voices kept coming out. The fact that technology or the digital health or mobile health, all of this has enabled not just them to deliver healthcare as a health aid, the digital health, but also as a way of continuous learning or refresher learning, or even better able to provide, whether it's counseling or awareness to the community that they serve. Now, the questions remain from a community health worker perspective in terms of how can this voice of this extremely sincere, committed, probably very resourceful community health worker, how do their ideas, how do their suggestions get amplified? How do their voices reach directly to the higher levels to shape the health system, to shape the community needs that they serve? What will be their role like as it evolves in terms of, there's always the contrast between there is a role as a healthcare provider for the community versus the need within a vertical healthcare program. And in every webinar, we've also seen questions raised to us about, raised to the panelists about what is the similarity or the contrast between the community health workers and their urban counterparts? How much is similar? How much is different? What will work? Also, how do we look at technology to allow them to share best practices with each other? In these webinars, we were also able to bring some of the community health workers from different parts of India to speak. And one of the thoughts that they left with us was very often, this was kind of the first opportunity to kind of share and listen to each other's story. Today, with this technology, how can that be fast-tracked? How can we enable that cross-pollination of learning to happen? How can the community health worker who work despite so many challenges have access to resources or address her own perhaps mental well-being issues? So these are some questions to reflect on at the individual community health worker. The second part is related to the community. The community health worker comes from the society that is probably reflective of perhaps a patriarchal, a very gendered kind of systems in place, which also means that maybe women are the focus and not necessarily men in terms of recipients of care. But in terms of the kind of challenges that these health workers have to face in the community to serve, and the kind of the innovations that they have done in order to kind of navigate, whether it is family members who are not supportive, or it is in the community, whether it's the caste system or different things that they've had to navigate. It is extremely critical that the community becomes far more powerful. So here, we really need to understand what can the community do to enable the community health worker in terms of enabling technology usage. For example, how can the community ensure good connectivity so that if she has to use, let's say, an app or a mobile, she's able to? How can the community provide better access or linkages? Evidence has already shown that her status as far as the primary healthcare staff is concerned, the community health worker has managed to, uplift her status so that the primary health center functioning is quite dependent on what the community health workers are doing. So how can the community serve better resources? What are the priorities in that community? We saw several examples of how they interface not only with the local panchayat, but also with the local self-help groups and other resources which might be available in the community to ensure that care is provided for everybody. So this set of questions remain, that without community participation, this will not work. So what is the kind of involvement the community should have versus the health system? And more research will be required to find these answers. The third part goes to the health system itself. And here, there are some, like well-known facts. For example, hand hygiene, a basic behavior which is expected, and yet one that is so difficult to follow. And we have seen that even during the COVID times. Now, why am I talking about hand hygiene? I'm only using it to illustrate as an example that without the community health system and the community health workers, we cannot provide healthcare. This is a well-established fact. And yet, even though the community health workers constitute approximately about 43% or probably around 50% of the entire human resources in healthcare, their positioning is extremely low. And in today's webinar, this was reiterated by the different panelists. So we really need to understand, how do we significantly raise the stature of the community health workers as vital to the health system survival, not just for a referral upwards, but the costs that we can save through better preventive healthcare or with quicker identification of high-risk cases. The health system is also required to think through. In the webinars, we looked at what kind of supportive mechanisms are there, like supportive supervision. And while there is so much of focus on the performance of the health worker herself, there needs to be a better focus on what kind of supervisors and what kind of training do the supervisors get so that they can enable the community health worker to perform better. What kind of coaching or mentoring can the community health worker get? Perhaps the older, the senior community health workers, can they switch onto a coaching or a mentoring role for the junior community health workers? How can this also become embedded in the system? There were evidence which brought out the community health worker is quite adept at the technology. The supervisor also, but perhaps not to the entire technology, not to the dashboards. Community health worker provides the data. Yes, I'm just concluding.
I'm sorry to interrupt you. In fact, I think some of the panelists also have to get on to other calls and other things. So we would just like to close.
Yeah, so I'll conclude in a sentence or so. So the health system, it's extremely vital that the questions come into how do we strengthen, as mentioned, the financing, the research evidence of ensuring community health system can continue. So in conclusion, the series may have ended, but the discourse, the research, the evidence, this will continue for this very needed topic to improve healthcare for all. Thank you.
Thank you. Thank you very much, Dr. Preeti.